So we're open for questions. We're supposed to stop at 11:15. It's 11:09, so I think we have time for maybe 3 or 4 questions.
Here we go. I'm Bob Kushner from Northwestern University in Chicago. Thank you, Nikki, and Bruce, and Lou as well. In our center, and I think it's common among all the centers of excellence, follow-up care is really challenging. Patients really don't come in. As the farther out from surgery, the less often they do come in for care. So your story, Nikki, I think is more unique than typical. And I wonder if any of you had advice on how to improve the follow-up care that patients should be getting in the bariatric surgical space, but are just not returning.
We find that's tough as well. I think the way that we do it is using a carrot, which is, if you're having any trouble, so basically we see people annually for their vitamin and nutrient profile, but we'll tell people at the first sign of any weight gain, if you're hungry, we want to see you right away. Like we look at it the way a cardiologist looks at chest pain. And that, we find, gets people to come back because they hit bumps in the road, they're willing to come back. They also realize that we get it, like we understand their problem. And so the patients who we see, who we send out, tend to come back, but I'm not saying that would be true everywhere. That's what we do.
We provide a packet of information that is intended to be used by the primary care provider regarding what should be followed and what to look for because many of the patients have traveled a distance. Distances are bigger in the West. We have people from Alaska and Montana and so on, that they just are not going to be able to come back to Portland, Oregon for all of their visits. So we're looking to provide an educational material. If there was an obesity medicine specialist in their community, that's great. There often is not, so we're looking for an intermediate way to provide information.
I can also provide an answer to that. In the Kaiser system, where we have a shared electronic record and it's integrated, we have developed some smart sets in Epic for labs that are needed, and we also have an advice referral function that allows our primary care physicians to consult with us and with our surgeons when they need to know what to do with a micronutrient deficiency, for example.
From the patient perspective, I would say that something that you said in your presentation is very important, which is that surgery alone is not intended to be the cure. There is this misconception in the patient community that the surgery is supposed to be the end of the line for your obesity treatment, that you should not have to be required to do it, not on the perspective of I shouldn't have to do this, but I am a failure if the surgery did not completely resolve my obesity. So there's a lot of shame that sort of keeps people from going back to their surgeon. I interact with hundreds of post-ops every day through my online community who are straight out ashamed to go back to their surgeon or are waiting to lose 10 or 15 pounds before they go to see their surgeon about problems, which is sort of working against what they want to do. So pointing out to your patients at the outset of treatment that bariatric treatment may not be the only intervention required to treat their obesity, and to stress that it is sort of a lifelong approach that they're taking, and a lifelong thing that they're embarking on is probably also helpful in getting people back into the room on long term.
Bill Dietz, Redstone Global Center for Prevention and Wellness at George Washington University. Thank you all. And Ms. Massey, I was curious. We're very sensitive to the issue of stigmatization and bias. And I wondered 2 things. First, whether the stigmatization of obesity is what kept you out of primary care offices, that kind of interaction. And secondly, how your social interactions may have changed and the response of others to you may have changed following surgery.
I don't think that stigmatization kept me out of a primary care physician relationship. I just totally unrelated. I have some addiction history in my family, and so those sorts of things sort of just kept me away from. I have like a very strong aversion to anything that reads as medication, so my bariatric staff actually worked with me to get on bariatric specific chewable vitamins to keep me compliant with them, because it was just such a strong connection there. I would attribute that more to my aversion to physicians was doing anything that involved drugs or medication or anything like that. Anytime I tried to interact with my primary care physician about weight, it was always a very uncomfortable conversation, and it usually resulted in me being given a copy of the food pyramid with very little explanation. So I didn't know what to do with that. And so I'm also like a very practical person. If I feel like something is a waste of my time, I'm not going to do it. So it's, I just didn't find the advice that I was being given very helpful. And I'm sorry, I didn't completely hear the second question.
So it was about changes in social relationships following bariatric surgery and whether the perceptions of others and the way you were approached differed.
For me, well, social relationships in general completely changed for me after bariatric surgery. I recall before bariatric surgery, as a part of my job, I was required to take the Myers-Briggs personality test, and I was very surprised that I was labeled an ENFJ, an extrovert. I did not identify as such beforehand, but those relationships do help affirm me in my post-operative care because of the fact that I get a lot of value out of talking to other people about my experiences and hearing their experiences back and giving support and lending support. I feel like peer support is a very important part of aftercare with weight loss surgery. I feel like peer supporters have to be very careful not to try to imitate medical professionals. On my platform in my community, I always send people to their professionals if they ask a question that is inappropriate for me to answer. And that alone has made a big difference in the last few years of how I've carried out my own aftercare, as being able to effectively talk to people, effectively present myself in front of people. Although sometimes it feels a little bit funny to me to be a peer leader when I've experienced regain. Again, that goes back to that sort of sense of shame that you can sometimes experience in feeling like bariatric surgery is supposed to be the end of the line. But in the social relationships that are built and the whole culture that's built around weight loss surgery, there is a lot of affirming power, I think.
We routinely counsel patients to be prepared for friends, family, and others to be unkind and not happy for them because they have lost weight but have other negative responses.
We should stop, right? So, okay. It's 11:15, so I guess we'll have to have you ask your questions during lunch or during a break. Thank you to all the speakers.